Hey, Dr. C here. Today I'm going to continue my conversation about the 4 pillars of pain control. As I've discussed in previous videos about how you can manage your own pain, I break pain control down into 4 pillars. There are 4 things you can do for yourself. You can detox, you can ambulate, you can hydrate, and you can meditate. Each of these is a rather broad topic, and there are many subsections under them. And I just use those terms so that it's easy to remember and you understand that there are a number of activities that you can engage in to help control your own pain. So I'm going to continue with my meditate or meditation section, or the meditation pillar of pain relief, by discussing a little bit more about mood and pain. We've known for a long time that you have control over how you perceive your pain. And I did discuss this a little bit in an earlier video. Well, we also know that mood impacts the way we experience our pain. We know that people who are in good moods tend to have less pain than people who are in poor moods. And we know that depression and pain go hand in hand. In fact, I would estimate that upwards of 75% of patients that routinely seek care in a chronic pain practice have some degree of depression. And I'm not saying that there's anything unusual about that. If you go through life day in and day out with pain, it can be very depressing to know that it's not going to go away or it's not going to be completely relieved. However, if you don't get the depression under control, it's very difficult to get the pain under control. When we look at brain scan studies of the brain, either with positron emission tomography, or called PET, or functional magnetic resonance imaging called fMRI, we're actually able to see the physiology of the brain as opposed to the anatomy of the brain. When you look at a regular MRI or CT scan of the brain, what you're getting is a snapshot of what's inside the skull. But you're not really getting any idea of how the brain is functioning, what the brain is doing inside there. You can just see that it's there, or in some cases not there. But for the most part, you can see that there's a brain that is there, and you can look at it anatomically and you can see, oh look, it's all the parts are where they belong. There's no tumors, there's no infection, there's no bleeding, there's no gross abnormalities. But you can't tell much about what the brain is doing. But these other studies that I mentioned, PET and fMRI, these are functional studies. These allow us to look at what the brain is actually doing, how it's thinking, or what parts of the brain light up when it's thinking. And with this information, we can start to understand the pathways that generate certain emotions. We can see different areas of the brain light up when somebody's depressed. And while it's not a truth scan, it does give us a pretty good idea if you are depressed, and it can give us a pretty good idea of how profoundly depressed you are. We can also, to some extent, see pain. We can't tell where the pain's coming from. We can't tell if it's pain because you've injured your back, or the pain from a previous injury that you've never learned to cope with that still persists, or if it's pain from something that's never going to resolve. We can just see that there are certain areas of the brain. They used to be called the pain matrix, and they go by various names, but there are parts of the brain that are visible and metabolically active. They light up on fMRI or PET scan, and we can see them when we scan patients. And what we've learned is that there's a lot of overlap between mood and pain. And we've also learned that if you treat one component, you can often help address the other component. So for example, when I was a fellow at Stanford, we were doing work with profoundly depressed patients who had chronic pain that was recalcitrant to all therapy. It didn't matter what we did, we couldn't relieve their pain. Almost always, these patients were also profoundly depressed. And we found that if we couldn't control the pain by traditional pain relief mechanisms, we could certainly improve the pain and certainly improve the function by getting the depression under control. And in more than one case, that I was involved in, it was decided between the psychiatrist that was involved in the patient's care and the patient themselves to use an old technique called electroconvulsive therapy, or ECT, to treat pain. And this was a technique to treat depression, which was, again, recalcitrant to therapy. It would treat depression that just wasn't responding to conventional means, or would treat depression in patients who were at risk for suicide. And it seemed to be very effective in getting the depression under control. And what we learned was that it would also get pain under control. And I would see this handful of patients that we treated actually respond to the therapy, the ECT therapy, from a mood standpoint. You could see their whole persona transform. They went from completely expressionless, speaking in monosyllabic terms, having very little to say, to slowly becoming more and more animated as the ECT therapy went along. And then they would start to groom themselves, and they would start to just look better. Their facial expressions were better. You could see that they were feeling better. And then you could test them, and you could see that by testing that their mood had improved. They were no longer as depressed as they were before. And we could do the same thing with pain. We could talk to them about their pain, and we could ask them questions about their pain. We could do pain questionnaires, and their pain scores actually declined. They got better. And we could also measure it. We could do certain testing on them, generally exposing them to painful stimuli to see how much they could tolerate. And what we learned was that as the mood improved, they were able to tolerate more pain. And so there was actual evidence that their pain thresholds had increased. The pain threshold means you can tolerate more pain before it interferes with what you're trying to get done. And this was done back in when I was a fellow in the year 2000, 2001, and we didn't invent the technique. I was just witness to it at that time. And so with the combination of fMRI and these other researchers that I've described earlier, Beecher and Ekman and Deutsch, and the things that I witnessed with ECT to correct severe depression, I'm convinced that if you don't control your depression, if you don't get your depressed mood under control, you're going to have a very hard time getting your pain under control too. And there are a lot of ways to go about treating this pain that may or may not give you relief. But what I'm certain of is if you have an overlying depression and you don't get that managed at the same time, nothing is going to be particularly effective for you in getting your pain under control. This is not an indictment of anybody. This is just stating the cold hard facts. You've got to control one in order to control the other. In fact, we used to have arguments back and forth with the psychiatrist at Stanford, because he would tell me, just control their pain and their mood will get better. And I would say, well, if you control their mood, their pain will get better. And we were both right. And both of our jobs were really difficult because, as I said, this was a difficult population who had tried everything already. But we found that by using uncommon techniques to solve one problem, we were getting results for another. And it's interesting to me because I read some multiple pain journals, and just recently I saw somebody publish an article about using the old technique of ECT to relieve pain. Now, 24, 25 years after we were doing it at Stanford. And I have to wonder how many years earlier somebody else had reinvented this wheel before we started to adopt this technique for pain control as well. The bottom line is, if you don't control mood, you can't control pain. And so it's not a waste of your time to engage in these psychological approaches to pain control, because these psychological approaches to pain control also have a great deal of benefit for controlling mood. And since we know from brain studies that the two go hand in hand, mood and pain experience or pain perception, we know that if you don't control one, you're not going to control the other. I'll continue to expand on this topic in future videos, and if there's something in particular that you want to know, please comment in the section below, and I'll review it, and I will expand on it even further. I hope this video has been useful for you. Please like and subscribe, because if you don't like and subscribe, I have no way of knowing if I'm providing useful content. If you have any specific questions about the information that I've given to you today, please comment in the comment section. I will review these comments, and I will make videos in the future further explaining this information if there's particular interest. Any particular researchers that I've discussed today in this video, I will include in the links below so that you can do your own research and review what I've said and maybe learn more about this topic on your own, because that's really what these are all about, helping you to figure out how to help yourself. Thanks for watching.